My name's Andrew Harrison. I'm a doctor. I've been a doctor for 12 years. Before that, I was a programmer. And also my grandmother had Alzheimer's for many years, so this is a topic true to my heart. One of the big problems in elderly care, and particularly in dementia care, is polypharmacy, where patients take a large number of drugs. In the UK, there's 800,000 dementia sufferers, and 40% of them take over 5 medications per day. There's numerous medical publications on the topic, identifying it as a hazard because of several reasons. Number one, if you're on lots of different drugs, they can often interact and become harmful. It's obviously a big burden for the patient taking that many drugs every day, and there's a big cost for the National Health Service. This website is to try and address that problem and find out which drugs are the most important for the patient, and then they can perhaps consider not taking some of the less important ones. So this is the front page. The patient comes along, or probably their carer comes along and decides whether they've got mild or severe dementia. Then they put in the medications they're on. I put in 4 here. And then they can get a crowdsourced opinion on these drugs. So this is the result of the crowdsourcing. The left-hand column shows what carers think, and the right-hand column shows what experts, doctors think. So looking at these examples, paracetamol is a drug which is a painkiller, and most people and most doctors think that dementia sufferers could continue on that because it improves their quality of life. So they've got a lot of votes, so it's green for continue. If you look at menantine, that's a drug which is actually to treat dementia. So most carers would say continue on it, that's why it's green for them. But actually doctors have some suspicions about the drug, and it's not as effective as perhaps we hope. And so maybe only 50% of them say continue with it. Then atenolol and simvastatin are drugs for heart problems, and if you've got dementia, maybe you don't need them so much, and that's reflected. Both doctors and most people think maybe stop those drugs if you want to, or after discussion with your family doctor. And then you can join the discussion yourself and see how these conclusions have been reached. Here there's a space for you to add your own vote and also your own opinion, and then you can read the opinions of others. So this lady Julia says, regarding atenolol, which is a cardiovascular drug, why don't you stop it? She says, my father used to take this for his blood pressure, but he hated taking so many tablets every day, and when he got severe dementia, he did not exactly worry about his blood pressure. So I'm hoping that this tool can be used to reduce the burden of medications, and carers, patients and doctors can have a sensible discussion about the priorities for medication. Any questions?
Thank you.
Hi, I'll kick off the question. Zaina from Mars here in Toronto. So how do you think this tool is going to help deal with the first issue you raised about polypharmacy, which is drug-drug interactions? So is there any logic around if a patient has these 4 and someone else has those 4? Because it's not about the individual drugs, it's about the interactions.
Yeah, well, I think there's already some commercial products dealing with drug interactions, and certainly, but potentially that could be included in the website. But then a lot of interactions aren't really known because there's so many different combinations of drugs possible that you can't cover everything. But an enhancement would be, well, which would be planned, in fact, would be to include very specific, well-known interactions which do crop up in Alzheimer's.
This is Sunil Sharma. Just a quick question. So, interesting presentation. I'm trying to understand how this is a business, and is this something that you see as a combination of, say, a social network for doctors where they're able to confer with confidentiality and privacy, kind of like companies like Figure One that have launched in that space, and public inputs, I guess, or company, startups like, or sites like WebMD where people are really just airing their own opinions on drugs? And is this sort of a synthesis of that? And if so, what is the end game for how this is a standalone business?
Well, if you can reduce the number of drugs which people are taking, then obviously that's a big saving for whoever's paying for those drugs. And in the UK, that would be the NHS. So if you think about how many people, say, simvastatin costs £1 per month, And let's say, or of those 800,000 patients with Alzheimer's in the UK, say, and 40% of them taking more than 5 drugs, if they're all taking simvastatin, we worked it out earlier on, that would be a saving of £3.8 million. And so hopefully the National Health Service would think the cost of running this website would be more than paid back by the reduction in drugs bill. Next question.
Any more questions?
Yeah, hi, this is Arlene here. I was just wondering, in terms of the advice that comes out of this, what are you expecting people will do if it comes back suggesting they stop or they discontinue, that they would then go back to their GP or just discontinue?
Yeah, I think there's a clear message on the second screen that patients shouldn't really unilaterally just stop taking their medication. They should always discuss it with their doctor. But I think sometimes it's difficult for them to have a sensible discussion with their doctor because they don't really kind of know what the situation is. Whereas if they can go into the doctor and say, look, maybe 70% of people think, or maybe the carer will say 70% of people think this drug's actually not that helpful in Alzheimer's or dementia. What's your opinion? The GP may say, well, in your case, no, it's particularly useful because I know you've got vascular dementia, so you should keep taking the cardiovascular protective drugs. But at least they can have a proper discussion and spurs that discussion on, rather than just like blindly taking drugs. And I think according to some of the papers, doctors are inhibited from stopping medications themselves because they may have been started by another colleague and they don't want to overrule the colleague. But if they've got this opportunity to spark debate, then they can justify the decision more easily. And it's kind of empowering the patient, empowering the carer. Next question.
Any more questions from our judges? No? Yes.
I'm just wondering, this looks like more of a situation for a caregiver to keep track of this, and how is this going to follow on in the dementia journey? Initially, they're going to be looking at the drugs. For example, when a person leaves that doctor and goes to another doctor, say in a long-term care facility, do you have any sense of how this will carry on to that long-term care facility to keep track?
I think, that you're getting at, when I was a junior doctor myself, you'd often be admitting patients and they may come in on 10 different medications, and as a junior doctor, you don't want to override any of those medications, so you'll blindly copy the medicines they're taking in the community to what they're taking in hospital. And sometimes you have a very proactive geriatrician who's going to cross off lots of their medicines, but sometimes there may not be the opportunity for that. And so I think at each stage that a patient is transferred from one doctor into another and the drug charts are transferred over, it's an opportunity for a doctor to think, oh, maybe I'll question that, maybe I'll look it up on the website myself and see what my colleagues would suggest, other doctors would suggest, and then that might highlight a few drugs which they might consider stopping. So I think it would encourage doctors to review the drug chart more rigorously as well. Any more questions?
Nope, I think it's good. Thank you very much.
Okay, thanks.
Thank you, Team London.